Bismillahirrahmanirrahim. Hi everyone. Now this is the last video regarding the 6 ACGME called Competencies, and today we're going to talk about interpersonal and communication skills. So one good thing about communication skills is that they actually can be learned. So for example, in one report by Gordon, he mentioned that there is a greater likelihood of a resident improving his or her communication skills if they use evidence-based descriptions and demonstrations of their communication skills, if they use a conceptual model, so they basically just making your communication more structured, if they are able to practice skills and receive feedback by faculty or preceptors, or regular reinforcement by preceptors and application of skills during patient encounters routinely occurs. So it's kind of like a loop. The resident practices, and then in a structured manner or a structured fashion, and then he or she get feedback by the preceptor or the faculty. And also another report in 1993 by Levinson and Rotter demonstrated that videotaping or audio taping and interaction and receiving feedback from a standardized patient can actually improve primary care physicians' communication skills. So I think residents should take advantage of that. And if you don't have a structure or a model in your residency that teach resident how to improve their communication skills, I think it's really worth trying to pursue that. Okay, so having said that, the first sub-competency under interpersonal communication skills include patient and family-centered communication. Bedside manners and communication skills are really important for patients. So hopefully by the time of graduation, the resident already moved from level 1, when he or she can use language and nonverbal behavior to demonstrate respect and establish rapport between them and the patient, to level 4 and 5, when the resident can establish and maintain therapeutic relationships using shared decision making regardless of complexity, and can mitigate communication barriers. Basically, even for difficult cases, they're still able to maintain rapport with the patient and explain the plan and get the patient cooperated with them and understand, and the patient really understands, and the family also understand what's going on. So this really includes a lot of skills, and some of the advice I will give for residents. For example, always consider diversity and cultural, ethnic, spiritual, emotional, and age-specific differences. Sometimes especially for example for a young resident, talking to a young patient differs than talking to someone who is like 60 or 70 or 80 year old. And also talk clearly, talk slowly, try to listen when appropriate, even sometimes listen more than you talk, not just hear your patient. Learn how to ask open-ended questions, learn how to ask direct questions, and learn when to use lead questions depending on the circumstances. Be careful about your body language, that really matters, your facial expressions, your posture. A lot of patients can notice that. A family also who are surrounding the patient, if you're not talking to them directly, they can also notice your body language. Always think about, is this the right time to talk to my patient? Is it the right place to talk to my patient? If can I talk to the patient in front of the people who are present now in the room or not? If this is actually the right person to talk to, if you're talking to a family member about a patient who, for example, cannot do not have capacity or is in coma or something like that. And one nice thing or statement I like about communication skills that I always try to keep in mind is that if you cannot explain it in simple words, then probably you do not understand it well. So if you're trying to explain something to the patient and it seems like you're struggling, one of the reasons, not the only reason, but one of the reasons might be because you really don't understand exactly that procedure, or you don't understand the plan in a very clear manner. So think about that. Also, think about written communication for your patients. After the encounter, maybe you want to give them, some documents, some papers that discusses nutrition, discusses diet, exercise, these kind of things at the end of the encounter, so that they can go home and do some reading about it, instead of letting them read from other resources from YouTube or just Googling it and getting some information from biased resources. Also, and I think this is really key, is to be trained on how to communicate with, difficult patients, and how to, for example, de-escalate conflicts with patients or patient families, and also how to deliver bad news or difficult news, or how to have end-of-life discussions. This can be a little bit challenging, but again, with some practice, you can get better at that. And then learn how to build rapport and relationship, and align management with the patient goals. So try to understand the background of the patient, and understand their rationale for the decision that they want from themselves, and tailor the treatment accordingly. And now the second subcompetency is interprofessional and team communication. That's really important. So hopefully the resident will be able to move from level 1 when they can respectfully request and respond to a consultation, and use verbal and nonverbal communication that values all members of the interpersonal team. To level 4 or 5, when they can coordinate recommendations from different consultants to optimize patient care and facilitate conflict resolution between and amongst consultants when disagreement exists, meaning basically just more complex situation. So really that's really key, especially for inpatient setting, for acute medicine, hospital medicine. Communication skills is really key, and failure of communication actually is a major cause of inpatient errors. So be mindful about that. So we really expect the resident to be able to communicate well with the team, and that team will include resident peers, first, second, and third years, and also medical student if they have medical student in their team, with attendings, with night team when they do the handoff report. That's really key. That's actually considered one of the key timing during patient care in the inpatient setting, because it's really important that you give the night team a really good handoff report about the patient that you know well, and they don't know them as much as you do. So, and also incorporate feedback from your peers, from your attendings, from staff, from nurses. It's really key that you listen to other team members as well. So also communication with consultants, whether you are consulting them or you are in a service and you are being consulted. It's really important that you have good communication skills with the primary team and with consultants, and you know how to ask and provide consultation as appropriate. Also communication with nurses, I think that's really important. It's especially for the inpatient setting. Also communication with ancillary staff, with the physical therapists, with the social workers, with the case managers. All these are very key providers that are really play important role in the management of the patient, especially for the inpatient setting. Especially for me as a hospitalist, it's really important that you communicate with them really well, and let them know your plan, and make that clear in your documentation. And if there is a major change in the plan, it's always good to communicate directly with them. So the last subcompetency under interpersonal communication skills is communication with healthcare systems. That's mostly the charting, the electronic health record, and keeping and maintaining your notes. So hopefully the resident will be able to move from level 1 when they can accurately document comprehensive and current information, and communicate using formats specified by the institution policy to safeguard patient personal health information, or PHI. To level 4 or 5 when they can document clinical encounters really clearly, concisely, timely, and in organized form, including anticipatory guidance. Models, and they can actually they are expected to, by that time, to be able to model effective written and verbal communication. So basically what they're trying to say is that you write a very concise, neat, and informative note. HMP, history and physical, progress note, consultation note, test note, or even brief note, an update or something like that. These notes should be signed on time, especially progress notes, because they are written every day. Important event documented. If you have, my advice is whenever you have a patient encounter, you evaluate the patient at the bedside, always document that. And document that on timely fashion to document exactly when you did that encounter. And also, your residents will be expected to use the right means of communication based on urgency and situation, right? So if you know the patient having some issue with constipation, you can, when they, ask you to put some order for that, and you know that the patient is having constipation from this disease, then you don't need to go at the bedside and evaluate the patient if there is no, need for that. The patient is stable, but if there's a change in the vitals, or obviously there is a change in the health of the patient, then you are expected to go at the bedside, evaluate the patient, make your decisions, talk to whom you need to talk to, and then document all that by the end of the encounter. One more advice I would say that always try to learn from your program, resources available for you where you can improve your communication skills. So, for example, most of the programs have free access to Access Medicine, and really they have a lot of books, cases, that tackles communication skills. So, ask about the resources available for you in your institution. ACGME also has a few resources also, and some apps and programs available for residents, faculty, and residents of programs to utilize, that they can actually evaluate the resident and fellows' communication skills. So as expected, the programs, they have many different ways of getting information and assessing the residents' communication skills. So they can get it from different resources. That's called multi-source feedback, from nurses, from attendings, from peers, from patient surveys as well, directly and indirectly, from direct observation, from simulation and mock or standardized patients. So by this, I'm happy that we finished discussing the 6 core competencies, and I really wish that I was able to make them a little bit more easy to understand, and I really advise everyone before starting residency to get acquainted to them and know exactly what they are. If you have any questions, don't hesitate to post a comment or even email me or reach out to me through the contact information that I have in my channel. And thank you very much. Good luck.